presentation Professor Richard Bar. The first topic is elastography of the breast.
Thank you. I want to thank the committee for asking me to come. I really would like to share my experience with elastography. I've been doing elastography for about 20 years, so I've made every mistake you can possibly make. So I would like to share that with you so you don't make the same mistakes that I did. So elastography, first of all, for this breast, I have many slides that I'll never be able to go through all of them, but I included them so you have them in your syllabus. So I may go through some slides very fast, but all the information is in your book. So elastography is a new technique in ultrasound which can provide us information that we didn't have before. And elastography uses based on tissue stiffness rather than anatomy. And elastography has the potential to quantify the stiffness of a lesion, which was previously judged only by physical exam. I'm not going to go over this in detail. Dr. Dietrich did an excellent job in going over the difference between strain and shear wave elastography. But this is my physics slide for strain elastography. So if you had a bowl of Jell-O and then had an almond inside and we applied a force here with a spoon, the Jell-O would change shape a lot, but the almond would not change shape. So from that we know that the almond is stiff and the Jell-O is soft. And that's all these systems do, is they look to see how the tissues change as we do compression. And as Dr. Dietrich said, okay, thank you, that strain elastography is relative, and therefore we don't know how stiff something is. We can only compare it to other things in that image. So for breast imaging, it's very important to have many different tissues, because like in this next slide, where I have a fat lobule surrounded by glandular tissue, things show up nice. So the fat is very soft and the glandular tissue is very stiff. But in this image where I only have fat, a part of the fat is very stiff because it's, for whatever reason, stiffer than the other fat. So we really can't make a decision if something is stiff enough to be a cancer just based on strain imaging. And again, each manufacturer has a different amount of pressure that you have to apply to get a good image, so it's very important that you work with your vendor to know how to do this best on their machine. As Dr. Christoph said, there are many different color maps you can use. For my talk today, what I'm going to use is white is going to be soft and black is going to be hard. One of the things that was noticed in the early work with breast was that breast cancers appear larger on strain elastography than on B-mode imaging, and benign lesions appear smaller. So in this example, here you can see this lesion, which measured 7 millimeters, but it measures 14 millimeters on elastography. And this is very predictive of being a cancer. This technique, or this difference in size, only appears to work very well in breast. It doesn't work so well in other organs. But since we can't use strain by looking at what color it is or how stiff it is, this is actually a very sensitive way of determining if something is malignant. Or in this case, the lesion goes from 9 millimeters to 8 millimeters and was a benign fibroadenoma. And I'll show you our work as well as others that show this is extremely sensitive and specific for diagnosing, characterizing breast lesions. This is a paper that we looked at several hundred of our breast cancers, and we plotted that ratio. If we measure the length of the lesion on elastography and divide it by the length of the lesion on B mode, we say anything 1 or above is a cancer. And if we look at the different types of cancer, The lower grade cancers have a ratio of closer to 1, and we use 1 because we have cases of mucinous cancer or DCIS that are 1. So we always do a biopsy a lesion with a ratio of 1. And as you get to higher grades of cancers, that ratio goes up. And we've actually had lesions appear 4 times larger on elastography than on B-mode imaging. So this is, again, very sensitive. This is a case of a mucinous cancer, and you don't see it very well on the B-mode image, but you can see it very well on the elastography image. And this is another factor that you should realize, that in sometimes we may see lesions on elastography much better than we do on B-mode imaging, because the lesion is stiffer than the surrounding tissue, but has very similar acoustic properties. And the reverse is also true. If we have a lesion, like say fibroadenoma or fibrocystic change, we often see it very well when it's surrounded by glandular tissue because it's very hypoechoic and the glandular tissue is very hyperechoic. However, they have the same stiffness. So in that case, we may not see the lesion very well on elastography. We did a study that we presented at RSNA in 2006. We looked at 126 lesions that were sent to us for an ultrasound-guided breast biopsy. 106 of them were benign on pathology, and 17 were malignant. And if we look at the ratio, again, taking the length of the lesion on elastography and dividing it by the length of the lesion on B mode, if it was 1 or greater, all 17 cancers had a ratio of 1 or greater, and 105 of the 106 lesions had a ratio that was smaller. So we had a sensitivity of 100% and a specificity of 99%, which is almost impossible to believe we could do so well. So we led a multi-center trial with many sites around the world, including Europe and Asia. And we enrolled 635 patients doing the same kind of study. About 2/3 were benign and about 1/3 were malignant, and we had a wide range of pathologies. And presenting the information the same way, you can see that of the 635 lesions, 413 benign, 222 malignant. If we look at the ratio greater than 1, 219 out of 222, 99% sensitivity. And if you look at the 6 sites, 5 of them had 100%, and 1 site had 97%. And we learned a little bit of information from this, because these 3 cases were cases of DCIS, where the measurement, you couldn't see the lesion well on B mode, so we think they measured the lesion wrong. If you look at the specificity, it's much different, kind of a wider spread, but still a very good number of 87%. And we did this study before we really understood about pre-compression that I'm going to talk about shortly, and I think that was part of the problem with this, is that people didn't realize how to do a much better job. But you can see we're very happy with these numbers. And if we look at the ratio, the benign lesions went from 0.2 to 1.5. Again, we had 3 cases that were above 1. And all the malignant lesions were 0.9 to 3.1. I'm sorry, we had 3 cases that had a ratio of less than 1. And these are the scatter plots. And you can see there's a pretty good separation between benign and malignant lesions. Another observation that we had, this was using a Siemens system, was that we saw what we call the bullseye artifact. So we saw this artifact quite often, and we saw it both in what looked like simple cysts, complicated cysts, and actually a couple lesions that we thought were solid on B mode. And the bullseye artifact, here's a cyst on B mode. It's this black outer rim, a white inner dot, and a white distal dot. And you need all those components to call it a bullseye artifact. And when we looked at 127 of these consecutive lesions measuring from 2 millimeters to 4 centimeters, an average of about 1 centimeter. And of these, about half were biopsied and confirmed as simple or benign cysts. And the other half were simple cysts just based on B mode. There were no internal echoes and had through transmission and a very thin wall. And if we look, 90% of the cases had B mode image appearance of complicated cysts. And actually 6 of these we thought were solid. And using that bullseye artifact, all of these turned out to be benign cysts. So using this bullseye artifact to confirm a lesion as a complicated cyst even if it appears as a solid mass on B mode, we could have reduced our biopsy rate by 25%. And you'll see as we go through this talk and I show you how we've progressed, you'll notice that on that first study, our positive biopsy rate was about 20%. And you'll see now in our latest studies that our positive biopsy rate is 80%, because we've stopped doing biopsies in a lot of lesions that are benign. And we were worried with the bullseye artifact miss complex cystic masses. Here's a 2 millimeter papilloma. This was actually from Carmel Smith, who's in Brisbane, Australia. And you can see that we get the bullseye artifact, but where this solid lesion is, it shows up as being a defect in the bullseye artifact. So we feel very confident we can use this artifact to distinguish benign complicated cysts from complicated cystic masses. And again, we use that ratio of the length on elastography to B mode. That's what we feel comfortable with, but there are other methods you can use to interpret breast. And one of them is the 5-point color scale that Dr. Ueno has proposed. And a score of 1 is the lesion is very soft. A score of 2, the lesion is mixed, cystic, and solid. The lesion, a score of 3, the lesion is stiff but smaller than it is on B mode. A score of 4, the lesion is stiff and the same size as B mode. A 5, the lesion is stiff and bigger than it is on B mode. So we, in a sense, group 4 and 5 together and say it's a ratio of equal to or greater than 1, and 1, 2, and 3 that the ratio is less than 1. And the bullseye artifact only occurs in the Siemens and Philips machine. All the other vendors have a different artifact. That's the blue, green, red, or BGR sign that you see here, blue, green, red. No one has really studied this to make sure how confident we are that it's 100% going to show complex cysts as benign lesions using this artifact. Another method of looking at this is, although we don't know how stiff something is based on strain, we can compare how stiff it is to something else. And for breast, we're always going to use fat. And I like to use this study that was presented at RSNA by a group from Turkey that looked at 242 lesions, and about 2/3 benign, 1/3 malignant. And they found that if you put an area marker over the lesion and an area marker over fat and compared the stiffness values, if that was greater than 4.8, it was malignant, and it was less than 4.8 benign, with pretty good results. So again, using what's called a strain ratio, and you'll see that as we go to other organs, this is often one way of using strain. Again, the change in size seems to be very unique to breast. These are the results of a bunch of different studies. And you can see that some use the E to B ratio, some use the 5-point scale, some use the fat to lesion ratio or strain ratio. And you can see that even with the different methods, we get actually fairly good sensitivity, usually above 90%, and a specificity that's in the high 80s or 90%. So all these techniques work. We did a meta-analysis looking at a little bit over 10,000 cases and looked at the 5-point papers, the strain ratio, and the length ratio papers. And what we found was that we think that the sensitivity of the E to B is the highest. The specificity was very similar between the cases, but the most important thing here is the negative likelihood ratio. And you can see that the E to B mode ratio, that is 0.03. And what that means is if you have a negative test, that you can downgrade lesions. And if you did this mathematically, we could downgrade a lesion that based on BI-RADS had a probability of 50% being malignancy and drop that down to 2%. So we could downgrade even 4Bs using this technique. So this is a very important number, and we should have that out in press shortly. I'm not going to go over this in detail. This is, again, my physics model for shear wave. We apply our RF pulse. We generate these shear waves. They go faster in stiffer tissues. And I think one thing that's very important, we're using B mode detection pulses to follow the shear waves. So to do any of these elastography techniques, you have to have very good B mode imaging, because B mode imaging is what we're using to either follow the shear wave or see how the things change. So it's very important that you spend time getting a very good B mode image when you do these. If we do shear wave elastography, again, we get absolute numbers, and we can put our boxes. So here's a lesion. We put the box, so we have 3.4 meters per second, and the fat in the background is 2.5. We have a color scale, and every vendor is using red as stiff, and blue is soft, thank God. Here's another case where you can see we have some red in the lesion, and it's 6.96 meters per second, and the fat again is about 2.5 meters per second. So this is a benign fibroadenoma, and this is an invasive ductal cancer. And in our lab, we use a cutoff value of 4.5 meters per second, which corresponds to 60 kilopascals as our cutoff between benign and malignant. So for liver, it's very hard for you to change the shape of the liver by pushing with the probe because the ribs are preventing you from doing that. And that's one reason why we always recommend you do your liver elastography between the ribs and not in a substernal position. But in all the small parts that we're going to talk about, it's very easy for you to apply pressure with the probe when you're scanning. And when you do that, you actually make lesions stiffer. So you have to do all these elastography techniques with a light touch or very, very little pressure. And again, I call this pre-compression, and you want to use this light touch. And here's what we do for breast. If we have a lesion, and we're on B mode imaging, this is a rib. After we do our B mode image, because we usually like to apply some pressure, for breast especially, because it makes the Cooper's ligaments flat, so you eliminate a lot of refractive artifact. You lift up the probe, and as you lift up the probe, the rib will drop deeper into the field. And when you get to a point where the rib is as deep as it can go and you still have a good image, that's where you would do your elastography. And we published this quite some time ago, where we looked at a bunch of lesions using shear wave, and I applied different amounts of pressure. Okay, and here at about 40%, this is about the amount of pressure you would get if you were doing a mammogram. But you can see that as we apply pressure, every lesion, including cancers, gets stiffer. And the benign lesions and fat get stiffer faster. So actually, if you apply enough pressure, you can make any benign lesion look like a cancer. So again, this is very critical when you're doing elastography. The effects of this on strain imaging are, if you apply too much pressure, again, here's a rib, it's at about 1.2 centimeters, here it's about 1.7 centimeters, and here it's about 2 centimeters. There's a little epidermoid cyst here. If you apply a lot of pressure, all you get is noise. You really can't get any good information. If you apply some milder compression, you'll see the lesion, but often what will happen in strain, you'll get a good image, then you'll get bad images. Good image, bad image. Just as the patient's breathing or moving, as you release the pressure, you'll get a good image. As you apply pressure, you get a bad image. And if you do this right with very little pressure, you can see a very good elastogram in all the images. So when people call me up and say, strain image doesn't work, they're usually applying way too much pressure. If they ask me, I got this cine clip, which image do I use because it looks very different, they're still applying too much pressure. And then if they can get a consistent image, they're doing it very correctly. So that's a very important thing. When you do the cine clips, you should have pretty good, constant, stable evaluation. The same thing is true with shear wave elastography. Here we have a very simple cyst with no pressure. And again, here you can see a rib. And you can see that the rib is getting closer because I'm putting pressure. So here is exactly what we would expect. The cyst is very soft. As I start applying pressure, the colors get redder and redder. And I turn this cyst into a cancer by applying a lot of pressure. So it's very critical that you're doing all your imaging here and not doing this because you'll get bad results. So where do we use elastography? So we can characterize lesions as benign or malignant. And again, I use the E to B mode ratio. On shear wave, we use greater than 4.5 meters per second, or 60 kilopascals as our cutoff. You can help detect and delineate multiple lesions, and I'm very surprised that now we're doing elastography, how many lesions that we think is one lesion on B mode is actually two lesions that are adjacent to each other. on elastography. It helps us characterize some complex lesions. It's very a no-brainer to decide if something is a fat lobule or a lesion. And it really facilitates localization of biopsy targets. And the key here is you want to biopsy where the stiffest area of the cancer is. That's going to give you the best radiology-pathology correlation. So using the elastography, we can pick where's the best place to biopsy a lesion. And again, elastography is really an adjunct to your conventional exam, so you're always going to do your normal exam. Elastography was added into the last BI-RADS, not as much as I would hope, but I'm hoping in the next version that we convince everyone that we really should be doing this in every breast lesion that you do. Some quick examples. Again, this is glandular tissue. This lesion is somewhat irregular. This was sent to us for a biopsy as a BI-RADS 4B lesion, and it's obviously just a fat lobule on elastography because it's very soft, so this patient did not need a biopsy. So I show this because this is 2 artifacts in one. So when we look at this, remember I told you you want to have a big field of view and have multiple tissues in strain because you're always comparing different tissues. This is a lipoma and surrounded by fat. So there's really only one stiffness value, so you're always going to get a bad image. But I want to show this too because you see this right ring around the lesion. This is what I call the sliding artifact. So this is when the lesion is moving in and out of the plane. You get this artifact. So you know sometimes when you're scanning the breast and you go over fibroadenoma, you feel like it plops out. This is the elastography of it plopping out. Okay, so if you're doing this, it's telling you that this lesion is not attached to the surrounding tissue. And Dr. Nakashima from Japan actually says he can use this to look at DCIS to see if there's an invasive component, because if it's DCIS, he should be able to make this white ring around the lesion, or if it's invasive, he can't make the white ring. So he's doing a very good job at that. I don't know how many other people can do that. Here's another example of cases where we find this useful. This was a 40-year-old woman that came in that had a palpable mass. She had a mammogram and an ultrasound somewhere else. Her doctor sent her to a surgeon, and then the surgeon sent her to us because everybody feels this palpable mass. We did our exam and didn't see anything on B mode, but I put the probe over where I palpated the mass, and we get a perfect bullseye artifact. And this is an isoechoic complicated cyst. So we stuck a needle in and aspirated this, the mass went away, the lesion went away. So we use this quite often using the bullseye artifact. And you can see there's another little cyst here that's probably that you probably would never have known if you wouldn't have looked at the elastography. This is the case that I think I've learned the most about elastography. It was a woman that came in and had a new abnormality on her mammogram. And we almost always do all our biopsies under ultrasound if we can. And I like to say the lesion had a head, that I circled in red, a body, and a little tail that I put the green arrow on. And when we did our elastography, the body got bigger, the tail got bigger, but the head disappeared. So quite interesting. So we biopsied, and again, we always biopsy the stiffest area. This came back an invasive ductal cancer. So after she had her lumpectomy, I went to the pathologist and said, can you pull out the slide so we can figure out what's going on? This turned out to be a benign fibroadenoma that was attached right next to the cancer. So we thought in B mode it was one image, but in reality it was 2. And if you would have biopsied just this top part, you would have gotten a fibroadenoma and just the cancer. So again, using elastography is very helpful. This is just another example, taller than wider, probably a 4B lesion, but it got much smaller. And this is from the 1990s, so this is a very old image. But you can see that even on the old systems, we did very well with this. And again, it got much smaller, and it was a fibroadenoma. This is a case that's kind of an isoechoic lesion, but it had spicules, and I thought for sure this was going to be a cancer, but we got the bullseye sign. And again, I stuck a needle in and aspirated it, but it was so suspicious here we actually didn't cord out this whole area, and on pathology it was just a complicated cyst. Another case of an older woman that came in with a bloody discharge. Here's her lesion on B mode, quite complicated. When we look at the elastography, it has kind of 2 lobes here. One lobe is very soft, and one lobe is actually very stiff. So, because she had a bloody discharge, Old hematoma or old blood is very soft, so we thought this was actually blood, and we stuck a 20 gauge or an 18 gauge needle and aspirated this, and this was old blood. This stiff area, we did a core biopsy, and this was a invasive papillary cancer. So again, using elastography to decide how you're going to do your biopsy is very helpful. I showed you this before. This is this little papilloma, and you can see it really was 2 millimeters. So you can do elastography on very small lesions and get very good results if you train yourself to be very well. Again, this is one of the first cases we did back in the 1990s. This lady had an invasive ductal cancer. This was her lymph node. And here you can see there was some fat in the center of the lymph node that's white. But when we did the cortex, there was this area that was stiff, always on every image we did. So we guided the biopsy of this lesion under elastography, and this turned out to be a metastasis in the lymph node. So we can use this also in looking at lymph nodes. Another case, I thought for sure this was going to be a cancer. It has all these spiculations, it has shadowing. We do this, and if you look real close, there's actually a bullseye. There's the white inner dot, the outside black rim, and the white distal dot. And again, I mean, I would have called this almost a BI-RADS 5. So we actually cored this out, and it turned out just to be a complicated cyst. The biggest problem we have, the specificity, when we overcall, we call a benign lesion a malignant, was caused by this in strain imaging. So again, here we've got encircled in red a lesion that's hypoechoic, and it's surrounded by glandular tissue, which I put in the green dots. And when we do our elastography, and this is one of my mistakes when we started, that it looked like, to me, the lesion actually got much larger. But when we biopsied this, this was just fibrocystic change. And the reason is the elastic properties of fibroglandular tissue is the same as a fibroadenoma or the same as fibrocystic change. So what here is a combination of both of these. And this is just to show you examples. In this case, where we've got this hypoechoic lesion surrounded by glandular tissue, we don't see the lesion very well. It blends in with the same elastic properties as the surrounding tissue. But in this case, where we have a hypoechoic lesion, the lesion is very stiff compared to the glandular tissue. So this is actually a benign lesion, and this is the malignant lesion. So whenever we have this appearance of a hypoechoic lesion surrounded by glandular tissue, if it's a cancer, we get this appearance. Just a couple other examples where, again, looks like one lesion on B mode. Actually, it's a cyst in another lesion. Another lesion, again, a little cyst attached to another lesion. So using elastography, we get some information that we may miss on B mode imaging. Again, we talked about shear wave imaging, and I think it's the same as Dr. Dietrich said about liver. We put the big box, we get the colors. Breast cancers tend to be very heterogeneous, so we always use the stiffest value to make our diagnosis. So here, this is 123 kilopascals. And again, I use 60 as the cutoff. This was a mucinous cancer. And this is just to show you, this is the strain image, and it went from 14 to 18 millimeters. So in this case, both the strain and the shear wave imaging allowed us to make the diagnosis. And we'll talk a little bit about that. This is from the WFM guidelines paper that is freely available on the WFM website, that we looked at here, the 5-point color scale, using red is soft, white is soft, and blue is soft. And if we use the length ratio, or the strain ratio, or the shear wave data, and we used a BI-RADS score, so a BI-RADS probability score. So 1 is definitely benign, 2 is benign, 3 less than 2% chance of malignancy, 4, 3 to 90, and 5 greater than 90%. And you can see all of the different ways of interpreting whichever method you use. And those are still, that's several years old now, but I think that's still pretty good. And we went by the literature as to how to split these up. So I think we did a very good job, and I think that would be a very helpful paper for you to get started. One of the problems with shear wave is, for the size criteria, you need to see the lesion well, both on the B mode as well as the elastography. And oftentimes with DCIS, or invasive lobular cancer, we don't see the lesion very well on B mode, and therefore we sometimes can't use this. And we'll talk about using shear wave in conjunction with this to help this out. And you know, we'll probably never be able to do screening with strain image because it's relative. So there's no way we can do that. Maybe with shear wave elastography, where we get the absolute values, if we can do it in a reasonable amount of time. Right now, it just takes too long to do that. But I wanted to go over the problems with shear wave. And again, this is something that's, again, relatively unique to breast. Some people call them blue cancers or soft cancers. Actually, these are very, very stiff cancers. So these are the cancers you have a hard time putting a needle in because they're so hard. But on shear wave, they appear to be soft. And the reason is, and about 25% of our cancers are this way. And you may see a ring around the lesion, which is a clue. But here's an example. An invasive ductal cancer. It's soft on shear wave, but it's obviously very positive on strain. Some other examples, and again, every shear wave system does the same thing. There's no difference between the vendors, and all of the strain systems say it's positive. So it's not a problem with the vendor, it's a problem with the pathology, the histology of the lesion. And we looked at the shear waves coming out from this, and this was published several years ago, that in the cancer, we only get noise. And the system interprets that noise as a very slow shear wave speed. And often if you look at this, this is showing that the lesion is actually softer than fat, which is probably not possible. But in this case, you can see the ring around it, and the ring has more curves that are interpretable. But occasionally, you don't get the ring, so you can be confused. So we worked with Siemens to develop this quality map, which looks at the shear waves and determines were they adequate enough to get a good number. And we use a stop sign. Green is go, yellow is caution, red is bad. So to be able to get a good measurement, we really should be doing this in green. And I think a lot of vendors have now included this in liver, and it'll be coming more and more into liver, where you can see that although we've got values plotted on the velocity map, all this whole area where the lesion is really bad shear waves, and you shouldn't believe that data. And we published in Radiology several years ago, again, if we did just strain imaging, shear wave without the quality measure and shear wave with the quality measure, and if the quality measure was poor and the lesion was solid, saying it was a cancer, we almost got as good as strain imaging. So in our hands, strain is more sensitive. We feel better with that for cancers. And the problem with strain is, again, if you have a benign lesion in glandular tissue, it's hard to see the lesion. Their shear wave is much better because you get an absolute value. So again, we like to do the combination of the two. So we can see that in this case, it's positive and positive. Of course, this is a false positive. So even though we do a good job, there are a couple things that are always false positives. So meaning it's a benign lesion that we think it's a cancer. And the most common are fat necrosis and mastitis. A very small number of fibroadenomas, and they tend to be the ones that are growing fast, will also show up as being false positives. So these are the things to worry about for false positives. And the only false negative we've had has actually been lymphoma. So lymphoma is a soft lesion, so you have to be careful. And again, both on shear wave and strain, the lesion is benign. But on biopsy, it was lymphoma. And these tend to be very vascular lesions. So half the cases we have, we knew the patient had lymphoma, which is a good key to know. But the other half, we made the diagnosis of lymphoma by biopsy the breast lesion. And again, if we've got this hypocoel lesion and it's very vascular, we're very concerned that it could be a lymphoma. So both strain and shear wave provide additional information on breast lesion characterization. Technique is critical, and it's always done in conjunction with B-mode imaging. At least in our hands, strain has the highest sensitivity. We feel we don't miss cancers, only lymphomas. And shear wave has the highest specificity. And again, we like to do both, because if they're both the same, we have very high confidence we're making the right diagnosis. And there's a significant improvement in sensitivity of the 2D shear wave with the addition of the quality measure. So again, these problem with the blue or soft cancers we can solve by adding this quality measure, and I think all the vendors will eventually have this on their system. And again, we like to do both. It really improves our confidence. Other things to remember, that the technique and interpretation of strain images varies with each manufacturer, and it's the amount of movement you have to do. So some systems, like the Philips and the Siemens, require really just the patient breathing. Other systems may require you to move the probe, and they often have a little bar or a quality number or something that tells you when you're in that sweet spot. So if you don't push enough, you get bad results. If you push too much, you get bad results. So you have to learn how to find that sweet spot to get good images on your system. And again, we've gotten very good results, and in sites that we've really trained very well can do this. So training is very important. At least in our hands, our sensitivity is at least 98%, 88 to 99%, depending on the studies. And our specificity is on the order of about 90%. And again, fat necrosis, mastitis, and a few fibroadenomas, we end up biopsying. And again, if you look at our studies, our positive biopsy rate was about 20% when we started, and now it's 80%. So the number of biopsies that we have eliminated is huge. And we make a very big impact on women. And we do this real time so that we tell the patient the results when she's there. And it's very helpful for them. And they're all very happy if we can cancel a biopsy because she doesn't need it. Really only adds a few minutes once you're trained. And again, I like to say it better selects which lesions need to be biopsied. We've eliminated a large number of biopsies. And again, I would like you to remind you that you have to feel comfortable with the technique and feel that you're doing good and confirm that you're doing good before you start canceling biopsies. And then, you know, one of the things that I'm very interested in is, for some reason, all these things are very unique to breast. They don't happen in any other organ. We don't know why. And it's not because it's desmoplastic reaction, because why does a benign lesion get smaller? There's no anti-desmoplastic reaction. So we really don't understand what we're doing, but we know from doing thousands and thousands of cases that it works. And we do this in every one of our breast cases, and like I said, we've been able to really decrease the number of biopsies and remarkably improve our accuracy in characterization of breast lesions. Thank you.
Thank you very much. Very interesting about breast elastography ultrasound. And now we continue with the second topic around about thyroid ultrasound. Please.
Okay. So I'm a very, very big believer in breast elastography, and like I said, we do this in every one of our cases, and we feel very confident when we cancel a biopsy or tell a patient it's benign. Unfortunately, I'm not quite there yet with thyroid. So thyroid lesions are very common. They occur in about 33% of adults, and 50% of patients over the age of 65 will have thyroid lesions, and this is a very big problem. We very rarely see normal thyroids. And ultrasound is very highly accurate in the detection of thyroid nodules, but it's not very good at predicting malignancy. And B-mode features of microcalcifications, marked hypoechogenicity, taller than wider, thicker, regular, or lobulated margins, and microcalcifications are predictive of malignancy. And specificities and sensitivities range very widely in the literature. And part of this is because of selection bias. So some centers only pick patients to do biopsies that have very high chance of having malignancy. So they get very good sensitivities and specificities, where other centers pick biopsy every lesion that comes in, and this causes you to have less sensitivity and specificity. I like to show this table from Rago that goes over all these different signs and what the sensitivity and specificity of these lesions are, and you can see that none of them are really great. So although we can't see lesions very well in B-mode, we don't do very well in predicting if they're benign or malignant. And focal FNA is kind of the method of choice for diagnosing these suspicious lesions. However, the positive biopsy rate in a lot of studies is very low. One of the things that I'm very concerned about, I reviewed a paper of someone that did FNAs, and there were a group of FNA patients that were negative that they went to surgery. And of that group, 28% of the FNA negative with a good sample turned out to be cancers at surgery. So FNA is not really a good gold standard. So I think we have to be very careful when we look at data when a FNA is used as the gold standard. So the American Thyroid Association recommends FNA of nodules greater than 10 millimeters for having suspicious features. In the US, there are at least 5 different recommendations that vary from biopsying everything to biopsying only things that are greater than 2 centimeters and have calcifications. So it's very confusing, and there are now, I think, 4 ThyRads, things that came out, so again, very confusing. And the specificity ranges from 60 to 98%, and sensitivities from 54 to 90%. And indeterminate and non-diagnostic results are very common. So in our practice, we get about 15% non-diagnostic results, and we have to repeat those biopsies. And a lot of these are just colloid cysts, and if we don't get cells, which we're not going to get from a colloid cyst, the pathologist is going to call it indeterminate, and the doctors keep sending them back for repeat biopsies. The overall false negative rate of thyroid FNAs is 10%. And like I said, I had reviewed a paper that was actually almost 30%. And they say we can reduce that by doing a second FNA. And patients with false negative FNAs have suspicious sonographic features. You should consider reaspiration. And if we think they're very high probability of cancer and the FNA is negative, we ask the surgeon to take it out. Going over technique for strain, the amount of compression release, again, varies with vendor. It's very hard to do thyroid because the neck is curved and the probe is flat. So you need to have to do this so you're applying the same amount of pressure on the probe. You can't put one end with more pressure and the other end with less pressure because now you're causing changes in the stiffness between one side of the probe and the other. So it's very challenging. And another problem is the carotid artery. As the carotid artery pulses, it's actually changing the stiffness of the thyroid. So you want to avoid patient motion. You want to try to eliminate the thyroid pulsation as much as possible, and often doing it longitudinal is probably the best. You want to set the field of view so that the lesion is at least 50% or less of the image. So again, when we're doing strain imaging, we want a bunch of different tissues so we can see the difference in how that tissue relates to the other tissues. So in thyroid, we want to try to include the lesion, some normal thyroid, and the strap muscles to give us a variability. There are several ways of interpreting the strain images, and like I said, the elastography ratio of B mode to elastography to B mode image does not work well with any other organ other than breast. And I'll mention one little comment about that a little bit later. And you can do either the color scales, which we'll go over in a minute, or you can do the strain ratio, where you compare the strain of the lesion to normal thyroid, or you can use it to compare it to muscle, and there are different studies. And you have to make sure you're using the values from the paper you're doing. So if you're doing muscle, make sure you're using the cutoff values for muscles, not normal thyroid. And again, Wayno has this is a 4-point color scale, where 1, the lesion is very soft throughout the nodule. 2, the nodules are predominantly soft with some stiff areas. 3, there's a presence of a large area of stiffness. And 4, the nodule is completely stiff. Another scale is a 5-point scale that other people use, and again, very similar to what we talked about with breast. 1, the lesion is very soft. 2, there's components that are soft and hard. 3, the lesion is stiff and smaller. 4, the lesion is stiff and the same size as B mode. And 5, the lesion is stiff and bigger than it is on B mode imaging. If we look at the inter-observer variability, the kappa value is very different, pretty drastically from 0.6 to 0.95. And again, the reason is this is a very hard exam to do correctly because of the anatomy, the position, the carotid ultrasound, the carotid pulsations. So you really need to learn to do this technique. It's very, very difficult to get very good results consistently. Again, if we look at the literature, these are from different papers. You can see that we've got sensitivities in the high 90% and specificities in the 80 to 100%, but I'll tell you that there are a lot of papers that say that this is worthless also. So if you look at the literature, it varies greatly from being a very good test to a very bad test. And again, that goes to the technique is very critical. If we look at the strain ratio, you can see that there's a difference between different studies. And the cutoff value is somewhere around 4. So if the lesion is 4 times stiffer than a normal thyroid, it's probably a malignant. If it's less, it's not. So here's some examples. This is actually a strain image, and you can see that the lesion here, blue is soft. The lesion is relatively soft, and this is a benign lesion. Here I'm doing strain ratio, and I'm using a black as stiff. And here you can see that the strain ratio was 5, which we would predict as being a malignant, but this was not malignant on biopsy. Benign lesion with a different vendor. Here's the lesion, and here's the normal glandular tissue. We get a ratio of 1.9, and this was a benign lesion. We can also do ARFI strain. So instead of using the ARFI pulse to look at shear waves, we can look to see how the tissues move, which is strain. And here's a benign lesion. So this is VTI on the Siemens system, which you can use. We find it a little bit more difficult, but if you wanted to do that, you can. The shear wave technique, you're always going to use your linear probe, minimal pressure. Lots of cupping gel is very helpful, particularly in these organs that are not flat, because you can use the gel to make sure you're applying the same amount of pressure and using the gel to fill the gaps. You want to have the patient hold their breath, and usually you have to wait a couple seconds for the system to stabilize, and then you must hold the transducer still and try to minimize the movement from carotid artery pulsations by choosing a plane that's as far away from the carotid as you can. Normal thyroid has stiffness values of about 2.0 meters per second or 20 kilopascals. And again, if you look at the literature, the cutoff values between benign and malignant vary from anywhere from 34 kilopascals to 66 kilopascals, or 2.5 meters per second to 2.8 meters per second. And again, here's a meta-analysis, and again, here we can see sensitivities that are in the low 80s as opposed to the other ones that I showed you, and specificities about the high 80s and 90%. So again, the results are very variable depending on the site and the experience of the person. And just to show you some examples from our center, this is a B-mode image, very vascular lesion. When we do shear wave elastography, it's very stiff. And again, cancers are very heterogeneous, and we want to use 2D shear wave because we can see where the stiff areas are. If we use point shear wave, we don't know where to put the box. If we put the box here, it would have been benign. If we put the box here, it would have been cancer. So in all these small parts imaging, using the 2D shear wave is much better than doing point shear wave. And again, same thing here. You can see it's very heterogeneous. Always pick the stiffest area. And that was a true papillary cancer with stiffness value of 1.4 kPa. Another lesion, very vascular. There was a papillary cancer. And again, you can see the lesion is very heterogeneous, and it has a 100 kilopascals in the red area. But again, notice how different the lesions are. So again, it's very important to do this under 2D. Another lesion that turned out to be a papillary cancer. However, this lesion is a papillary cancer, and it's the same stiffness as normal thyroid. And we have many, many of these cases that we've had surgically positive lesions, and their papillary cancers are as soft as a normal thyroid. And we also have benign lesions that are stiff, that turn out to be malignant. So there's a lot of overlap between benign and malignant lesions. Another patient that had a long history of masses, extremely vascular lesion, positive on shear wave, but all of our biopsies in this patient have been negative, and those lesions have been there for 10 years and not changed. You can get some artifacts from shear wave, simple cysts will not transmit shear waves, so you will not get color coding of those. So they'll show up as black without color coding. Something called the bang artifact. You may get a very stiff area right underneath the probe because we have a very high RF pulse hitting the skin. So you may oftentimes see that red, sometimes releasing the pressure from the probe. We're using a lot of coupling gel is helpful. And in thyroid, calcifications are very problematic too. If they're macrocalcifications, they can affect our results. And one of the things that Dr. Dietrich mentioned about the liver capsule, that we get a reverberation artifact, we can also get that from the thyroid. So you have to be very careful that sometimes around the the thyroid capsule, you may get some stiff areas, and that's just artifact from reverberation artifact if you're hitting that capsule just right. So again, limitations, inter-observer and inter-observer variability is very great in this. Non-viscous fluids do not support shear waves and are therefore not color-coded, so it's very hard to analyze cystic thyroid masses. Point shear wave, the area of the highest stiffness, cannot be determined, so we don't want to use that. We always want to use TD, 2D, so we know where to put our box. In small nodules, we may have an ROI problem, that the ROI, you can't make it small enough for the lesion. And again, cystic regions and calcifications can yield false results. Another complicating factor is if we look at follicular lesions, so Dr. Samir from Mass General looked at only patients with follicular cancer, and the cutoff value is much lower. It's almost the same as normal thyroid. So in his series of follicular cancers, the cutoff value is almost the same as normal thyroid. So it's very hard. So we are probably going to do much worse in picking up follicular cancers than we are in picking up papillary cancers. The American Thyroid Association did a meta-analysis, and their conclusion was there was a wide range of cutoff values, therefore a threshold recommendation between benign and cancerous thyroid nodules could not be provided from this meta-analysis study. However, 3% of nodules that shear wave classified as benign were misdiagnosed nodules representing papillary cancer. And our experience is actually even higher than 3%. So where do we use thyroid? So in breast, I cancel breast biopsies all the time based on elastography, but I never cancel a thyroid. And there's 100 nodules. So what we do is we use elastography and we find the stiffest nodule and biopsy the stiffest nodule because we think that would give us the highest probability. And again, a benign lesion and it's false positive. And again, we see so many of these, I'm very concerned, and I don't want to cancel a biopsy because we've had too many lesions that turned out to be papillary cancers and had very soft elastography values. In diffuse thyroid disease, a study group reported in two studies that the statistical differences in RF stiffness between normal subjects and patients with autoimmune pathology with values of 2.1 and 2.7 with a pretty good p-value, and they suggest that RF seems to be able to predict with sufficient accuracy the presence of diffuse thyroid disease with an area under the curve of 0.8, which is not great but okay. And they use 5 measurements to obtain a median to do that. So to conclude, malignant lesions are statistically stiffer than benign lesions, but there appears to be moderate overlap. Cutoff values vary widely as sensitivity and specificity, and we really have no uniform technique. Additional studies are needed to standardize the technique and interpretation, and to my knowledge, right now there are no studies that correlate elastography with thyroid results. So negative elastography should not eliminate doing a FNA if the B mode is suspicious, but could prompt an FNA if it's positive. And again, we really need to look at studies using surgical results as opposed to FNA because there are a lot of problems with just doing an FNA. Thank you.